Hi, good morning, good afternoon, good evening to the first of a series of three webinars, which is done by FIGO on the FIGO Postpartum Initiative. Today we will have a three-country perspective on training and partnership for quality of family planning services. And I forgot to say that I'm Peter Steyn from WHO in headquarters. Next slide, please. So the program for today is quite a full program. You can see that there. We will have an introduction, then we will have 4 presentations, and we will have some time for questions and answers afterwards. Next slide, please. So just some logistics. The webinar recording will be available at that link, and it will be sent to you afterwards. During the call, during the recording and the presentations, you can submit your questions anytime on that will come to us, and we will allocate them to different. If there are a specific speaker that you want to ask it, just put that in parentheses, please. And then also, if you look at on the right side, there are 5 handouts at the moment that is available. Next slide, please. So first of all, I would like to ask Sir Arukula Kubaran, who is an Emeritus Professor of Obstetrics and Gynecology at St. George's University of London and visiting professor at the Institute of Global Health, Imperial College, and also past president of FIGO, RCOG, and BMA, and most important, the initiator of this FIGO Postpartum IUD initiative, to give us an introduction on the topic. Over to you, Professor.
Thank you very much, Petrus, for the kind introduction. Good morning to all from London, to the panelists, to the participants, as well as the organizers. It's a great pleasure to be giving an introduction for this Postpartum IUD initiative. It all started in 2013 when we looked at the maternal mortality rate, which was not coming down as expected. So we wanted to do something constructive. The governments in many countries, especially with high maternal mortality, were focusing on increasing institutional deliveries rather than spending money on contraception. And there was an unmet need of contraception, as well as we thought we should make use of the opportunity to introduce postpartum contraception within the institution. So we had some brainstorming with the donors, and we found that the governments are unable to supply hormonal contraceptives because they're expensive, they need some checking, whereas if it is a long-acting reversible contraceptive like a copper IUD, they were quite happy to participate. However, the literature was rather varied about the expulsion rate, ranging from 4 to 16%, and we found some publications with the use of Kelly's forceps after vaginal delivery. This can be reduced. So we started the pilot project in Sri Lanka for a period of 12 months just to see the acceptance, the expulsion, the complications of infection, perforation, etc. And that was found to be very reasonable. And we thought we will expand this project to 6 countries. And the countries which were selected were Tanzania, Kenya, Bangladesh, Nepal, India, and Sri Lanka. And altogether, we had 48 countries participating in this initiative. And today, you're going to hear some innovative ideas produced by the country leads of the PPIUD initiative. And we learned as the FIGO PPIUD team a lot from the country team. So it was a mutual learning exercise and providing the best care in counseling and the contraception to the women. We also had in mind that many of these countries were offering permanent methods like sterilization to young women, and this we thought was not reasonable and we thought we will offer birth spacing by long-acting reversible contraceptives. I'm glad to say that now many countries are using copper IUD, not only the developing countries, but also the developed countries. And also this use has expanded to give a choice to the women, in addition to the copper IUD, the implants as well as come into use. So with that, I would like to thank Dr. Anita Makins and her team in FIGO, as well as the country teams, some of whom we are going to hear today, for their magnanimous effort in bringing this initiative. And this 7-year program is coming to a close by the end of December. And we like the audience to listen and to see whether you can start this initiative in your own country, in your own hospital, and help us to provide the much needed contraception to the women, especially when they come to the hospital. So there won't be much expense associated. My special thanks to the anonymous donors who gave us the funding to do this initiative. So with that, I would like to thank everyone and hand it back to Dr. Petra Stein, the chair of the meeting. Thank you.
Okay, I think I'll go ahead. So my name's Anita Makins. I'm the director of the PPIUD initiative here at FIGO. So first of all, thank you for taking the time to listen to our webinar. This is the first one of 3 webinars over the next couple of weeks. We're really humbled by the response that there has been to the interest that has been shown and, with the registration numbers. So for those who, sorry, if you could move on to the first slide, please. So I'm going to talk about the PPIUD initiative and why we believe it's a global opportunity to meet the, to address the unmet need for contraception. So FIGO, for those of you who don't know, is the International Federation of Obstetricians and Gynecologists. We have 132 member societies, and we're dedicated really to the improvement of women's health and rights globally. Next slide, please. So many of you will be aware of this data. So Guttmacher estimated that in 2017, there were 214 million women that had an unmet need for contraception. 95, and the other statistics on this is that 95% of women in their first year postpartum say they want to avoid giving birth in the next 2 years, but 70% of them are not using contraception. So the unmet need is really high in the immediate postpartum period. And one of the big reasons for this is actually just simply access to services, contraceptive services. The graph on the right shows over time the sort of gradual decline there has been in the unmet need, but really since about 2010, 2015, so the black line represents the world, and there really hasn't been much progress at all. And there are disparities in different regions of the world, and you can see there that Africa is the region of the world with the highest unmet need. Next slide, please. So another reason we're interested in contraception, so Professor Errol Kumran's already mentioned that family planning alone has the potential to reduce maternal mortality by 30%. So you can see the report on the right, and we've got a list of health interventions there, and family planning alone reducing it by 30%, which is sort of not the automatic way you would think about how you would address maternal mortality. Usually we'd be thinking of dealing with the direct causes, but actually, because family planning is a preventative measure, it's a very powerful intervention. Next slide, please. Again, further argument for providing contraception postpartum. So birth spacing makes a big difference on outcomes. So you can see the graph on the left is looking at the adverse outcomes when you compare women who space their birth by 18 months, less than 18 months, compared to women who have birth spacing of between 24 and 60 months. And you can see there that where your adjusted odds ratio is much higher for small for gestational age, for preterm birth, and for infant mortality. So So just a reduction in your risk of your pregnancy if you can birth space more adequately. And then the graph on the right is looking at, it was data put together in 2008 by Rutstein, pooling together from demographic health surveys across, I think, 40 plus low middle income countries. And what he showed very clearly was that as your birth interval increases, the chance of under 5 children being alive and not undernourished is also much higher. So benefits not only to pregnancy in the neonate, but also to children up to under the age of 5. So unsurprisingly, the WHO recommendation is that we should leave 24 months between births. Next slide, please. So Professor Alcom has already talked a little bit about why we focused in on PPIUD. So really it was an opportunity to capitalize on the sort of wave of increasing rates of institutional births that was happening across the globe following the MDGs. PPIUD is the medical eligibility criteria 1, so that means that it's got relatively few contraindications when you compare to some of the hormonal contraceptive methods. I mean, you don't put it into an infected uterus, so chorioamnionitis would be a contraindication. Obviously, if a woman's having a heavy bleed, also not, but bar that, really, it can be used fairly universally. It's a long-acting reversible method. It's got a very low failure rate, less than 1%, because it's user independent. And the subject of our third webinar about the cost, how cost effective actually the IUD is widely available in low middle income countries, actually around the entire world, and is out of patent, and cost is less of an issue. And then lastly, to say that if it's put in the uterus immediately after delivery, so within 10 minutes of birth of the baby and the placenta coming out, it is relatively painless because the cervical canal is already dilated, already open, and so less discomfort for the lady. So next slide, please. And then really to put it into the current context of the COVID pandemic, this is a statement issued by the Committee on Contraception, FIGO's Committee on Contraception and Family Planning, where we spoke about how contraception is an essential health service during the pandemic. And actually the first that came up with 6 sort of essential action points. And the first one really is highlighting how important the birth or the obstetric encounter, if you like, how important it has become, because with women not wanting to access hospitals with fear of infection and so on, actually coming to hospital to give birth is an opportunity to have all kinds of other healthcare that you otherwise won't get, and contraception should be high on the list. And more importantly than ever, the long-acting reversible contraception is incredibly useful because the woman doesn't have to come back for repeat supply. So in this sense, the PPIUD is almost more important during the pandemic than it ever was before. Next slide, please. Next slide, please. Yeah. So in terms of the implementation, again, Professor Alcom's already outlined. So we started the pilot project in Sri Lanka in 2013, and that was very successful. And so moved then into 5 other countries in Nepal, India, Bangladesh, Kenya, and Tanzania, and partnered with their national societies to implement the initiative. So our aim was to institutionalize the practice of antenatal counselling in postpartum family planning broadly, and then to teach the insertion of PPIUD, and obviously in those women who were consenting for the method. So it happened across 48 different referral hospitals. We chose places with large maternity units, more than 5,000 births. And as the project went on, other hospitals peripheral hospitals were also incorporated. Next slide, please. So in terms of how we started, so our training method was the training of trainer approach, which was then cascaded into each facility. And there were 2 components to training. First of all, counselling, and this was, we taught staff how to do balanced, non-coercive counselling in all the available postpartum family methods, and this varied from country to country as to what was available. And then the second part of it was training on insertion of PPIUD using the long-handled Kelly's forceps, training essentially on Mama U models. I don't want to steal the thunder of future presentations, but some of the highlights. So task sharing, Dr. Hema Divakar is going to talk about that next week, and that was a key component of our work. On the job training, Dr. Kusum Thapa hopefully will talk about this as part of this session, and inclusion of PPIUD in pre-service training was also key to sustainability in the long run, and Professor Munganyizi will be discussing that today as well. Next slide, please. So this graph shows sort of the spectrum of services provided by cadre of health. So you can see that the two African countries, Tanzania and Kenya, the dark green line are insertions by doctors, the lighter green are nurses and midwives. You can see in Kenya, Tanzania, the majority actually of insertions were performed by midwives or nurse midwives, and we actually looked at the complication rates and published on a comparison between complication rates in insertions that were performed by midwives versus doctors, and there was no difference at all. So absolutely safe to be task sharing with nurses and midwives in our initiative. Next slide, please. So this slide's really just showing you the number of providers that were trained. So the graph is those that were trained in both counselling and insertion, but we did also train some staff in counselling only, depending on the reality in country. But over 9,000 people were trained in counselling and insertion, and plus 12,000 just in counselling. And you can see the spread in the different countries there. Bangladesh and Tanzania were the two countries which we have stayed in the longest, and so hence the larger number of people trained there. Next slide, please. So in terms of service delivery, I guess the key thing to point out really is that we had this standardized methodology throughout the countries. So in every country, staff were taught to insert using this longer Kelly's forceps, which is 33 centimeters long. And the reason that matters is because it allows you to put the coil at the fundus of the uterus, and we believe that makes a big difference in terms of the chances of expulsion immediately after. So using a sponge holder is just too short and you can't achieve a fundal placement. And our data, we had an expulsion rate equal to that of the interval IUD, so just under 3% or around 3% across the countries. And some highlights, again, these will be discussed in later webinars, but in the different countries adapted the initiative to their realities. So for example, in Bangladesh and India, they had dedicated family planning counsellors, and Professor Parveen will be discussing that next week. We did produce communication tools, so information education communication tools, which included videos which in the local languages which women could watch whilst they were sitting in the antenatal clinic waiting for their appointments, to help sort of disseminate information about contraception, postpartum family planning. And we did also, with time, involve community health workers, particularly in Kenya and Nepal, and this again will be a subject Dr. Elia Dongo will be talking about that next week. Next slide, please. So these really are the results of the first, so we had 3 phases. The first 2 were the ones where we were really collecting data using data collection officers. So we did exit interviews to all women in the facilities where we worked, and those who had PPIUD inserted, we then collected data on the outcomes at 6 weeks when they came for follow-up. So you can see there, the beginning of the initiative, the blue line is numbers of deliveries in the unit. So up until mid-2015, we were just in Sri Lanka, and then mid-2015 added the 5 countries. The orange line is the number of women that were counselled in postpartum family planning. So obviously as training of staff expanded, then we get this increase in the number of ladies counselled. And generally, so across the board, about 12% of women who were counselled on postpartum family planning would choose the PPIUD. And so in total, you have there more than 74,000 women actually receiving the postpartum IUD. Next slide, please. So really another strong component of the initiative was leadership and governance, and we believe very strongly that strengthening our national societies in country to become true advocates for women's health with their governments can make a huge difference, and we've employed that throughout this project, and I know FIGO believes that very strongly. Obviously, we leverage FIGO's global influence to also to change practice, and we also made sure that we had these very robust data collection systems, so scientifically sound data could then be pulled together and analysed, and the London School of Hygiene and Tropical Medicine helped us do that so that we could then publish in peer-reviewed journals and add to the literature on postpartum family planning and also the safety of PPIUD. Next slide, please. So this really is just a summary of our theory of change. So you've got the 4 pillars at the bottom there, which I've talked about, so leadership and governance, training workforce, ensuring service delivery was of high quality, and making sure we collected data appropriately. And so this then translates to a health system which was better equipped to provide postpartum family planning and PPIUD, which in turn resulted in an increased use of modern contraception and better birth spacing, and also a decrease in unintended pregnancies and unsafe abortions. And our outcome at the end being reduced maternal mortality rates and improved perinatal outcomes. Thank you. So please. Next slide. So this is my last slide, just to give you a summary really of the key learnings. So firstly, the quality postpartum family planning is absolutely vital. That PPIUD is a safe and effective method to use, and it's possible to implement these programs fairly easily. Task sharing needs to be a really important component in order that access is there for everyone. Champions, I haven't spoken much about that, but certainly champions within each facility are really important. This isn't something that you necessarily identify at the start, but as the project moves on, there were individuals in hospitals who really made the difference and with making the initiative work. Community involvement, so the involvement of husbands and partners and community health volunteers in order to get that information across to the wider community, very valuable. Data drives change. Just to mention that in our sustainability phase, moving from data that we were collecting on our project, we were then trying to influence government HMIS systems in country so that when the project ends, the data is still being collected on postpartum family planning indicators so that can be used to ensure that things are ongoing. The partnerships foster sustainability, so above all the partnerships with our national societies and with the implementers. And then lastly, again, this is the subject of the third webinar, which I urge you all to join, which is just actually how highly cost-effective postpartum family planning and PPIUD services can be if they're rolled out at scale. So they benefit not only the women and their families, but also much wider benefits in terms of healthcare savings and benefits to the economy of entire countries. Thank you. Next slide. So I'm left really, sorry, one thing to mention, that we have 5 handouts attached to this webinar, so please take a look at those if you want more information and you haven't got time to listen to all of our lectures. I wanted to thank the entire team. You can imagine this was a huge endeavour across many countries. Some are in this picture. This was taken at the end of phase 2. Some people joined us afterwards who aren't there, and some had left by the time the picture was taken. So thank you all for your efforts. We've got the different national societies who participated in the London School. Thank you very much. So absolutely special thank you to my team, headquarters, Emily, Annabelle, Susanna and Catherine, who have done a fantastic job over the last few years and to put this together now. And lastly, just to say thank you again, I know Errol has, but to our anonymous donors for the very generous grant, which we hope we used wisely. Thanks very much.
Thank you very much, Anita. Next slide, please. So next up will be Professor Ratnasiri from Sri Lanka. He's a consultant obstetrician gynecologist with almost 30 years experience in the field and working presently at the Castle Street Hospital for Women in Colombo, Sri Lanka. He is one of the master trainers in the Postpartum IUD project, and his talk is on working alongside the government for nationalization. Next slide, thank you. Over to you, Professor.
Thank you very much, Strain, for the kind words. So good afternoon, everybody. I'm from Colombo, Sri Lanka. So my topic is the PPIUD initiative working alongside the government for nationalization. So I had the opportunity of involved in this project from the beginning 2013 and completing the project in 2018. Next slide, please. So when you look at the situation of family planning in Sri Lanka before the start at the initiative of 2013, so the Sri Lankan Government of Health, it provides free contraceptive for eligible population in the field and institutional care. So this includes emergency, interval and postpartum contraception. So according to the Health Bulletin, the National Bulletin of Sri Lanka, in 2012, 60.6% of eligible families had been using some contraceptives for their family planning. So if you see this slide bar chart, the right hand side, you can see in 2020, 64.6% of these eligible families using family planning as maybe a traditional or maybe the modern method. And we had unmet need of contraception about 7.3% in that year. Next slide, please. Next slide, please. So when we go into the details of the 2012 family planning, the oral contraceptives had been 10% and injectables, which was the Depo-Provera injection, 12.1%, and Intrauterine device, which is the green, had been 10.3% of the family planning, and implants were only a little amount, and condoms was 7.2, and LRT was 13.9. Remember, 10.3% of these methods were with the Intrauterine device, and among those 64%, 55% were using modern method and 9.5% were using traditional methods. Next slide, please. So in 2013, I had the great opportunity of participating in this initiative. So Sri Lanka College of Obstetricians and Gynecologists, with the partnership of government family planning. So Family Health Bureau initiated this project in 2013. So in the picture, you can see the Secretary of Health that time, so Professor Rabaratna Arukumaran, who was the project director of the PPIUD from FIGO, the Director General of Health Services that time, the President of the college and past President were there for the initiation of the project, and two of the trainers, master trainers from India, came to train us about the counseling and insertions. So we initiated this project in 2013 July, and we had pilot project in 6 facilities till 2014, and then we added 12 more sites. Those are hospitals, facilities with contraceptive and delivery care. So from 2015 to 2018, altogether we added 12, and altogether we had 18 participating facilities from the beginning. Next slide, please. So these are the hospitals, Group A, that was the initial hospitals, about 6 hospitals around Colombo and Kandy, Mahamudra. Those are bigger towns in the country, and then phase 3 was commenced in 2015 with another 6 hospitals. Those are in the periphery, and another 6 were added in September 2015. Those are also peripheral hospitals in the country. So we had altogether 18 hospitals in phase 1 and phase 2 PPIUD project. Next slide, please. So at the beginning, though the Intrauterine device had been modern method of contraception among our female. When we wanted to change the timing for insertion to postpartum period immediately, there had been some barriers, myths, and cultural problems. So to overcome that, Sri Lanka mainly we are using two main languages. So we prepared brochures and leaflets and distributed among the antenatal clinics, among the mothers, and also trained the caregivers, the midwives, nurses, doctors in the hospital. So all project hospitals we selected were visited by the trainers from the Sri Lanka College of Obstetricians and Gynecologists and Family Health Bureau. And we conducted several workshops on family planning, including the training on importance of family planning, counseling and insertions to the members of the staff who were involved in the maternity care in these hospitals. You can see these leaflets were prepared and distributed, and they were very helpful in accepting this method as a postpartum family planning. Next slide, please. So, in addition to visiting and training, the other contributory factors also were contributed for the success. The FIGO was involved in funding and providing all the support, and Harvard University was involved in the monitoring of the project, and it had been a very good contributory factor for success of the story. And the family planning director in the Ministry of Health, as a national program manager, was directly involved with this program, and the Director of Family Health Bureau, the Director General of Health Services, Secretary of Health regularly met, and we had very cordial relationship with them. And several times, Professor Arukumaran, the project director of the FIGO, visited, and we had cordial meetings with them and supervised and monitored the project. And we had several meetings with them during this pilot project period with the Ministry of Health officials like Secretary of Health and the Director General of Health Services. Next slide, please. So the phase 1 and 2 project summary, if you see the slide, up to June 2018, we had now in the selected hospitals 365,213 deliveries. And women were counseled for not only for PPIUD, postpartum family planning, half of them at least, 186,347. And out of them, 13,474 were counseled on the consenting from postpartum intrauterine devices. And we had the success story during this period. More than 10,000 IUDs were inserted in these two phases. Thank you. Next slide, please. So when you see the time period from 2014 to 2018, the number of expansion you can see as we have added more and more hospitals. So number of insertions, the green line shows it had been roughly around 2.3. The first one was 3.8, phase 2 4.3, and phase 3 average was 2.4. So roughly on average about 3% of women out of all deliveries were inserted with intrauterine postpartum intrauterine device. So it had remained the static throughout, because we have other methods of contraception, including the levonorgestrel implant, freely available for postpartum mothers in our hospital other than the sterilization. Next slide, please. So after in the phase 1 and 2 up to 2018, we followed up them for 4 to 6 weeks, and in group A hospitals we had the follow-up of about 33%, group B 44%, and group C 54%. So average of 41.3% were followed. And in this follow-up, we have seen 88 expulsions that came to 1.9%, less than what we saw in other previous statistics. And partial expulsions, that was, the loop has come down to the cervix in about 1.5%, and we didn't see a single perforation. So this had been a very good successful story for us to accept this as a family planning method for the nationalization. Next slide, please. So the FIGO team published an article, 4 years of the postpartum FIGO postpartum intrauterine device initiative in Sri Lanka. So in that we said unmet need depicted in the MDSR, the maternal mortality surveillance and program. We saw 7.1% of unmet need, and it has come down to 6.22 in 2016. And we had to overcome many barriers, political, ethnic, cultural barriers, but with time, education, counseling, we overcame this. And 2016 review of the initiative, we conducted a survey among our obstetricians, and we found 91.2% obstetricians were in favor of nationalization. So with that, we presented a paper to the Ministry of Health, the Sri Lankan College of Obstetricians and Gynecologists, with this success story. And in March 2017, the government accepted this as a national method, and it was with the other methods of family planning in hospitals and in the hospitals. Next slide, please. So we had to overcome some barriers, I said. So the monitoring team from Harvard, they published a paper regarding what happened during this period with the counseling. So ethno-linguistic concordance and the receipt of postpartum intrauterine device counseling services in Sri Lanka. It said family planning counseling material, brochures, as I said, were typically available and distributed in all 3 languages. However, even in the availability of these methods, shortage of multilingual healthcare providers may act as a barrier to effective counseling and communication of essential reproductive health function. The findings highlight the need for interventions that aim to bridge the socio-cultural gaps between providers and patients. Matching women and their providers on ethno-linguistic background may help reduce the disparities in care. So that was published in 2018, the Journal of International Perspective of Sexual and Reproductive Health. Next slide, please. So this is the member survey. So out of 74 consultants were contacted, and they were 91.9% agreeing as a method to be introduced to the Ministry of Health as a method, good method as a family planning, and only 3 or 8.1% disagree. And have you seen any complication infection? 50% has mentioned that never. And do you consider that specialist obstetric units in specialist hospitals to be the appropriate site? So 89%, nearly 90% agreed. So Sri Lankan College, do you consider to be the best agents to conduct training programs for counseling and insertions? Yes, 83.7% agreed. So this had been a very successful member survey, which helped us to provide the family planning services postpartum IUD. Next slide, please. So the government of Sri Lanka issued the circular. This is not only for postpartum IUD, postpartum family planning circular regarding the sterilizations, the insertion of IUCD postpartum, and implants, with the signature of the Director General of Health Services. So this circular was the key license for all our providers, members, to provide postpartum family planning to women in the country. Next slide, please. And also, the consent form was prepared. This also for both insertion of postpartum IUCD as well as the implants, levonorgestrel implant. So that was also published by the Ministry of Health, and this being used for postpartum family planning services currently in our hospitals. Next slide, please. So after the first two phases, we had to spread it to the other parts of the country. So some of the hospitals mentioned in this, we visited and trained the medical officers of health and the other doctors in the hospital on insertions, and the others like midwives, nurses, about 2,541 were trained on counseling for family planning. So after the first two phases, it spread to the whole country, and we had at least one master trainer in each of the districts in the country to train the newcomers for counseling and insertions at the moment. So this is the way that we spread our insertions to the whole country. Next slide, please. So with the heads of the departments and the medical schools, we had an agreement to include PPIUD insertions as a practical skill in the final examinations, as well as agreement with the health ministry, with the Secretary of Health and the National Head of Midwifery and Nursing Education and Training at the Ministry of Health to adopt program postpartum intrauterine device as a postpartum family planning, counseling and training material across all nursing and midwifery schools. So you can see two of these booklets were prepared. Actually, 2 days back, I had a training program for the new trainees of the Postgraduate Institute of Medicine for counseling and insertion of postpartum IUCDs in the college premises. Next slide, please. So after the initiative, I said we diffuse to the other hospitals where the specialists are working, providing family planning, and we did the nationalization and involved in the providing the equipments to the curative and preventive sectors, and task sharing with the master trainers, supporting further training to their people in the districts. And we wanted to have a training center in the Sri Lanka College of Obstetrician Gynecologist as the master training place. And we are the Sri Lanka College of Obstetrician Gynecologist responsible in training visiting obstetrician gynecologists in the future, and provision of mobile training kits for the master trainers for the years to come. Next slide, please. So with that, I like to conclude my thanking Professor Sabaratna Marul Kumaran, who was involved with this project from the beginning, Dr. Sanjeeva Godakandake, who was the project director in the Health Bureau, Ms. Flora, the secretary, and Dr. Anita Mackins, Ms. Susan Bright, and Ms. Annabelle Miller from FIGO, and all the other staff of the SLCUG for this preparation. Thank you very much.
Thank you very much, Professor Rapasiri. So we can move on to the next speaker, who is Professor Projestan Muganizi from Tanzania. He is Professor in Obstetrics and Gynecology at Muhimbili University of Health and Allied Sciences in Tanzania. And he was the national coordinator of the Postpartum IUD project in Tanzania, and will give his presentation will be on a postpartum IUD model working alongside pre-service school in Tanzania. Over to you, Professor. Thank you.
Thank you, Stein. I'm going to present the PPIUD model, how we implemented the PPIUD initiative in Tanzania. In particular, I will pay attention on the engagement of pre-service schools in Tanzania. Next slide. Yeah, so what I'm going to talk about is the pre-existing conditions before we implemented this, and how we implemented the program, and what were the outcomes. Next, please. Yeah, Tanzania is one of the countries with a very low contraceptive prevalence rate. As you can see, 32% of the women who are married were using modern contraceptive. And there was a very high unmet need of contraceptions among unmarried women. So overall, we had an intrauterine contraceptive device very much less used compared to other methods. In fact, in the community, it was less than 1%. And among the hospitals where we implemented this initiative, the women who were using contraceptive devices were just 0.18% before the initiative. And in Tanzania, midwives were not routinely allowed to conduct procedures that deal with the interference, so entering the uterine cavity after the woman has delivered. So PPIUD initiative had to introduce something which was not commonly done among midwives and nurses in Tanzania. And moreover, in our schools, the pre-service training did not include practical PPIUD training. So it was a very difficult context when we introduced this program. Next, please. Next slide. Yeah, the initiative was conducted in 6 sites. You can see on this map the dots. Those are the 6 sites where we conducted the initiatives. These are well geographically located, and these hospitals were in common delivering more than 5,000 women in a year. Next. Next slide. Yeah, the model in Tanzania for PPIUD implementation constituted a referral hospital in the center. And the referral hospital was responsible for training, PPIUD insertion, but also coordinating the satellite clinics. Each of the 6 sites that you saw on the map had about 4 to 6 satellite clinics. These are dispensaries and the health centers whose main function was to provide postpartum family planning information, and also counseling and the referral of the women who needed postpartum insertions. These referred women had to go and deliver in the referral hospital. So this was the structure in all the 6 sites. Next, please. Yeah, so the core components of our model were mainly 4. One was based on the competence-based training. The training was mainly competence-based. On a mannequin, they were trained on how to insert PPIUD on a mannequin using MamaU, but also the counseling. Counseling was also competence-based because they were doing this on cases, simulated cases. The second component was the standard practice. The practice was standardized in such a way that what was done in one of those units was done in all. We used the standardized method of insertion, standardized methods of training, standardized, we all used postpartum IUD insertion using Kelly's forceps, 33 centimeters curved. We all used insertion of the copper T 380A loop We all adhered to the same standards of insertion and the infection prevention. We all also used the same procedures for criteria for inclusion of the women. So what was done in one of those 6 components was also done in all others. So it was a kind of standardized practice. Another important core component was early and continuous postpartum family planning education. Those satellite clinics were mainly for this information. So we provided brochures, we had posters, we had standing banners, we had video. So as the moment the woman booked for antenatal clinic, she started to be exposed to this information. And she continued to be exposed to this information until when she completed her antenatal visits. So during that course, women who felt that they wanted to have the method done, they were counseled and they were identified and referred to the central training hospital where the IUDs could be inserted. So this was early and continuous postpartum family planning method education. Another important component was continuous data collection and feedback. In all the 6 units, we had some data collectors who were full-time employees who were there collecting data from every woman who delivered. And this data was about their contraceptive, their use of our services, and every information that was obtained from the women who have delivered, and this was obtained during the exit. It was uploaded in the tablet, and we accessed it at the headquarters. And therefore, we had a database, a huge database of women who delivered in all these units, and their preferences, their choices, and all their concerns. So this kind of information that we obtained were analyzed at the central level, and communicated. Feedback was regularly given to the facilities monthly. And also we had some kind of supportive monitoring visits to these facilities, where we had opportunities to meet and discuss with the local health leaders in that is the health management committees of those regions. So we had this kind of feedback, continuous information extraction from the women who were delivering or visiting the facilities. But this information was used to provide feedback to the facilities. This was another important component. Next, please. Based on the feedback we obtained, then we were able to do like a assessment, the assessment of strength, weakness, opportunities, and even the challenges that we faced during this. And then we found that the strength, particularly if we now start to focus on pre-service training, we had trained competent staff in all these hospitals. This was one of the strengths. And also there was availability of curriculums with family planning courses included in all the pre-service schools, the pre-service programs. So those were our key strengths. But also there was the readiness of hospitals to link with the schools for PPID hands-on training. So we discovered that we had those strengths, but there were weaknesses. The weaknesses include high staff turnover in maternity hospital. Therefore, in all these maternity wards, the moment you train, the nurses or midwives there would not stay very long. So that was a weakness. And therefore, we had to tackle this weakness. Also, there was lack of provision of PPIUD practical training in all pre-service curriculums. All the pre-service curriculums, they did not include PPIUD practical training. That was one of the big weaknesses that we discovered. And there was no formal arrangements to utilize the hospitals for family planning training, especially for PPIUD practical training. But there were some opportunities that we capitalized on. There was willingness to readdress for on-job, there was a readiness or willingness for on-job training. There was also willingness of students, teachers, and heads of school to teach practical postpartum IUD, but also routine use of portfolio logbooks for students. This was a very good opportunity that, although family planning PPIUD was not in their curriculums, but they had logbooks that were used for practical training. So we produced these logbooks and we inserted, instead of changing the curriculum that changes after 4, 5, 6 years, we only had to capitalize on these logbooks, talk with the heads of department, talk with the teachers, and see how we can include family planning in their syllabuses. So this is what we did. Next. Nurses were very important. We heard from Anita's presentation. In Tanzania, more than 60% of all the services, postpartum services, were provided by nurses. And therefore, in our training, we had to train more nurses so that they can provide more services. But this also was very important for the pre-service training, because nurses are the ones who stay in the maternity wards, in the labor wards for quite a long time. So what we did, these nurses became supervisors of the students who came to utilize their labor wards for postpartum insertions. So the use of nurses in the labor wards also tackled the problem of shortage of staff in the pre-service schools. So the moment these students came to the hospitals, there were trained, well-trained nurses. There was a mannequin there, a station, PPIUD station, which could be used for training of students and also demonstration of how to do it on students, and let the students do under supervision. Next. Next slide, okay. So the procedure that we used in engaging pre-service training was, first of all, we obtained stakeholders' feedback. As I discussed in the previous slides, that we were getting information. Information was coming from the hospital, coming to the headquarters, analysis, going back to the hospitals, but also we had meetings with the health management teams. And from there, we understood that we needed to include pre-service training in our program for sustainability of the program. So we conducted a study on the strengths, weaknesses, the opportunities, and the challenges. And after we analyzed the results, then we sought support from authorities, because we wanted to change the syllabi, but you can't do this without engaging the authorities. For the universities, it was much easier because the universities are more autonomous, and therefore you find all what you need there at the university. But for the midwifery schools and the other non-physician clinicians schools, we had to consult the Ministry of Health. And fortunately, the principal secretary gave a signature to endorse the change of the syllabus so that a practical postpartum insertion can be used. So we addressed the weaknesses, tapping on the opportunities available, and then we did training of the of the trainers, and then training of the students. And after we did all that, we linked the training, we obtained feedback from those who were trained from the schools, and we continued to see how they progress. But also we linked the schools with the hospitals, so that after the schools, after students have trained in schools, practiced on mannequins in the skills laboratories, they had also to go and practice in the hospitals under the supervision, so that they can practice on the real clients. So this is how we did. Next. So as a result, we had increased use of PPIUD. The counseling, if you look at this graph, the counseling started very low at 0.25. All these are the women who said they were counseled after delivery. But as we progressed, you can see the graph that there was progressive improvement after the model. And by April, June, 89.3 of all the women who delivered had some kind of information in the counseling. Next. Next slide. Yes. Now, the effectiveness of information delivery by the satellite clinics can be explained by this figure here. You can see that when we started in January, March, that's where we started the actual implementation. No woman who came to deliver who had information about PPIUD or who had cancelled about PPIUD. But as we progressed, the proportion of women with who said they were cancelled, they had information before coming for delivery increased, as you can see, until July, June 2017, where it reached 42.58. This is the proportion of women who came to deliver already with the information. From there, there was a little bit of slowing down because there were issues where the Ministry of Health had to call for the withdrawal of the information material which was provided on family planning. So during this time, something went wrong. There was a slowdown, but later on it peaked again. So this is the effectiveness of the satellite clinics. Information, women were receiving information from the satellite clinics. Next slide. This is PPIUD insertions. As you can see, PPIUD insertions also increased progressively from where we started, where it was very little. I said 0.18%, and these were few, 17 women had insertions. But by the time we reached April, June in that quarter, it is 1,545 women who had PPIUD insertions in that quarter from the 60 hospitals that we had. Next. This is PPIUD insertions per interviewed women. If we interviewed more than 80% of the women, all delivered women were almost interviewed. And in January, March 2016, when we started, after the women had delivered on exit, 0.18 had received PPIUD insertions. But as we progressed, 13.9, 13.4, you can see that there was almost a progressive increase in the percentage of women who received PPIUD. And among the 103,523 women who were interviewed on exit, 7.9% overall had IUD insertion postpartum within 48 hours. Next. Now the contribution of the students. The actual implementation of the students started during January-March 2019. As you can see, in 3 hospitals which were selected for this kind of insertions, you can see that 34.5% of the women who had IUDs, these were done by students under supervision. So the contribution of the students continued to increase after training and after enabling the institutions to train and also enabling the hospitals to provide supervision. Next, please. So in conclusion, the implementation of PPIUD model in Tanzania improved the capacity to provide PPIUD training, counseling, and service delivery. It was also very important to engage lower level health facilities in health education, counseling, and the follow-up, which prepared women to make an informed choice. Engagement of pre-service training for PPID is feasible by altering the syllabus without necessarily changing the curriculum. It is vital to influence training across all cadres of health involved in women's health. And you can see on the right, those are the kind of logbooks that were prepared and provided. Each of these logbooks has a PPIUD as a mandatory method for the students. So students had to do PPIUD insertions and observations before they were passed. Next. So I acknowledge all those who were involved in one way or the other, including the Ministry of Health, the facility coordinators, and the FIGO headquarters staff. But special gratitude to Professor Arul, who was very important for the initiative, starting of the initiative, but also he continuously guided us through the process. We are also grateful to the National Societies for Gynecology and Obstetricians, and also that for midwives of Tanzania for hosting the initiative. We thank all the colleagues and the PPID project headquarters in Dar es Salaam, whom I worked with in order to realize our dream. Thank you.
Thank you so very much. So we will move on to the next speaker then, who's Dr. Thapa from Nepal. She is a senior technical advisor at PPIUD and past president of the Nepal Society of Obstetricians and Gynecologists and vice president of the South Asian Federation of Obstetricians and Gynecologists. Next slide, please. Dr. Thapa will talk about on-the-job training in Nepal. Over to you, Dr. Thapa. Do we have Dr. Thapa audio right?
Not yet, Petrus.
So in
Anita
that case,
is working out.
So in that case, we will ask Dr. Anita. Unfortunately, we have some connection problems with Dr. Thapa, and I'm asking Dr. Anita Makens to do the presentation, please. Anita, can you unmute yourself?
Yes, okay, so I have Dr. Tapa actually on the line, so please let us know if you can hear her. She's going to go ahead now.
Okay, good morning, good afternoon, good evening to all.
We can hear you perfectly. Please go ahead.
Yeah, okay, can you hear?
Please go ahead, yes.
Okay, great, thank you. My previous speakers have already spoken about FIGO PPIUD initiative. And so in the next few minutes, what I will be doing is sharing about our experience of on-the-job training in Nepal. Next slide, please. In one of the field visits, we met this lovely young lady called Manu, and this is what she had to say. My body and mind feel so tired of bearing children again and again. I have not been able to find time for myself and give enough care to each of my young children. For those of us working in this area, Manu's story resonates loud and clear. We have heard from the previous speakers that postpartum family planning plays a vital role in preventing unintended pregnancy and reducing maternal child mortality. Yet, the unmet need for family planning is really high, particularly the postpartum family planning. And in one of the studies, which was done in Nepal by Mehta and al., it was estimated to be about 52% among women within the first 24 months after giving birth. Next slide, please. So we were really, we should really thank FIGO for supporting Nepal Society of Obstetricians and Gynecologists to implement this initiative in Nepal. And we worked very closely with the government of Nepal Ministry of Health to institutionalize and implement this in the big facilities in Nepal. So we really selected purposefully high volume facilities across the country. And these facilities had an annual delivery of almost about 6,000 to 12,000. So we thought that this is a great opportunity to be able to institutionalize postpartum family planning in the country, and therefore to scale it up further and address this high unmet need for postpartum family planning and be able to save our mothers and children. Next slide, please. So regarding the implementation, we worked very closely with the government of Nepal, and particularly because my focus at this point is on the job training, we worked very closely with the National Health Training Center, which is the apex body in Nepal and responsible for all in-service trainings in the country. Initially, the trainings, as Professor Arul and others had mentioned, was basically, and Anita has mentioned, it was group-based training, and this was started with training of trainers, and these trainers then did a group-based training in these facilities. But we realized after implementation over a period of time that we needed to be really flexible in order to respond to the changing circumstance and the changing environment which happened in our country. Nepal went through a devolved structure, and so we then had different provinces. Though we had deliberately tried to select health facilities to span across the different regions, we had to work extra to ensure that the provincial government and the provincial ministries were on board with this. The other thing what we had to add and tailor was the training of female community health volunteers, because in the national system, female community health volunteers, which are over 56,000 in our country, they have been trained for family planning counseling, but not for postpartum family planning. So we had to enhance the counseling skills on postpartum family planning. And we also realized that over a period of time with this devolved structure, we needed to have a different kind of training modality and work closely with the regional training centers within the provinces. Next, please. Next slide, please. So we needed evidence to be able to do what we were doing. So FIGO had conducted an in-service literature review looking into effective in-service training techniques, and some of the emerging evidence, which in that review they showed, was that learning was more effective when it was team-based, it was at workplace, if it was the content was spaced and new skills were honed in before additional skills were taught, and more important, in the use of appropriate dose and appropriate frequency. And they had done a number of studies to show the effectiveness of this review. So what we did then was, we used this principle, which the evidence of which FIGO had generated, to prepare something for our country context. Next, please. Next slide. So what we did was we prepared and worked with, again, with the National Health Training Center and Government of Nepal to develop this on-the-job training approach. And as evidence had shown that this has to be thoughtfully designed and sequenced, we did that, and we prepared a learner's handbook, facilitator's guide, and a logbook. Because of the appropriate dose, appropriate frequency, we realized that 2 hours of this training would be enough on a day, because it's on-the-job training and they had other work to do. So we designed it in such a way that it was a 2-hour training over 12 days, and the facilitators and the learners, they decided on when that 2 hours would be and which days of the week they would do that. So it was solely dependent on the team to decide how they would want to do it and when they would want to do it, using the standardized package. And the other thing which was this was all competency-based training. Another important thing for this on-job training was it was coupled with mentorship. Next, please, if we can just click. Here. So we had to convert these trainers, facilitators into mentors, which we did because there were additional skills which a mentor needed. And the mentors worked with their group of mentees in closely to make this effective. The other thing which was also used was a virtual assistant using the mobile phone, because that was what was there. And in this context, what I feel is, in this context of COVID situation, I think this approach is really a way forward if we want to continue building capacity of our frontline health workers to do the things they're supposed to do. Okay, next, please. We wanted to really evaluate this on-job training because we wanted to see whether this works. And particularly what we wanted to look at was what was the effect of on-job training on counseling and insertion. And the other aspect of this, what we wanted to study was, what was the perceptions of key stakeholders? Because we assumed this is working, this is good, but we really wanted to understand more from the end users on what they felt was the value added for this. And we've got this published in the FIGO journal for those of you who are interested in it. Next. Next. So some of the key findings was the government of particularly the National Training Center really embraced this, because for them it meant it reduced absenteeism and it was very cost effective. Because initially in group-based trainings, they had to pay for the DSA for the learners as well as for the trainers, and they would be away from their work site for almost 3 to 4 days. So this was something which was not costing the government anything. We did not have to pay for the trainers, or we did not have to pay for the learners. They just did it on their free time and they did it within the facility. Next. Next, please. So we wanted to understand what the views of the nurse who underwent this training was. And when I mean nurse, I also think about this nurse/nurse midwives, which is auxiliary nurse midwives. What they felt was that they had enough time to learn and practice counseling, which was really good. And the practice aspect of counseling, which usually just with a role play in a classroom, is not that effective. So they could practice it in real life with the mentors being there. And they could then provide postpartum IUD, whereas initially they had to wait because there were very few. When we do group-based training, we cannot produce large numbers of providers. So we had limited providers then. So they had to wait for them. But once they were trained, they could do it themselves. So they felt very empowered and they were really eager to continue doing this. The next, please. What I think this is something which we felt was really important, because before the training, what the nurse, one of the nurses mentioned was, before the training, women would be coming back to our service center for another delivery or abortion, because they were not doing this counseling that well. So with this training, what they felt was, because they learned, they practiced, and they had their mentors to support them, they could improve their counseling activities, and more women accepted IUD following the delivery. Next, please. We were very apprehensive about what the trainers felt, because they, I mean, like, it was an extra work for them. They were not paid. So we felt maybe we would have resistance from them, but they really felt that it was part of their work and they were helping the woman. And what they also said, that with this training, unlike the group-based training, the learners had more time to practice. And it wasn't that, okay, you have just 3 days, you have to practice, you have to learn, and then you don't get that opportunity again. So it was spaced, and they could repeat certain things which they were not confident about again and again under the guidance of the mentors. So I think the trainers and the mentors, they really liked this on-job training. Next, please. So we wanted to understand, did on-job training, okay, I mean, this is what the stakeholders or the end users mentioned, but what we wanted to understand is, did this have any effect on the counseling and the insertion trends? And what I would like to show in the slide is, regarding counseling, initially it was only about 13% when we started. There was some sort of counseling which was happening, and in spite of doing this group-based training, providers were there. They were a limited number, and they would always say that they do not have enough time, they have a lot of work to do, and so the counseling rate hovered around 13 to 15%. So looking at this and working with the FIGO team and Professor Arul and Anita, we decided, okay, let's have dedicated counselors so that they can support this. So we worked with the facilities as well as with the director of the facilities, and initially the project hired these counselors, but we worked very closely with them so that the directors, so that they could absorb these counselors and have it as part of their staff. So we were also working simultaneously with the director and with the facility in charge to ensure that they were part of their own facility and they were part of that staff team. And what we realized was, having this dedicated counselor, we had a counseling rate of 50%, but that was not enough. And obviously, she was doing her best, but it was only one person, and with those thousands of women, as I have mentioned earlier, it was challenging for her. So we were pretty happy with the 55%, and we were encouraging our providers to focus on counseling. And we introduced OGT. Little did we realize that the effect of OGT would be on the counseling, and what we saw was it just increased to 82%. So this was something which we found really encouraging with on-the-job training. Next, please. So regarding the trend in PPIUD insertion, when we started the project, it was about 2% insertions. So insertions were 2%, and this was more or less the national average. After we introduced the counselors, it sort of doubled to about 4%, but with on-the-job training and followed with mentorship, we had an insertion rate of about 6%. And these are in these big facilities with that high volume deliveries. So we still have a long way to go, but these trends seem to be encouraging. Next, please. So in conclusion, what I would really like to say is on-the-job training, mentoring has been perceived by the stakeholders as to be more effective than group-based training. And obviously it reduces absenteeism and is cost-effective, as we've seen. There is local ownership because the mentors feel so empowered now, and they feel that it is part of their job to really make sure that this OTT runs smoothly. So the facility coordinators and the mentor team, they are really taking this forward, and we've institutionalized it because we don't have anybody from outside who's working on this. It's the facility team who does this. What we felt was really important was regular reflections and feedback really help sustain skills of the mentees. So this, I think mentorship played a crucial role along with on-the-job training, because with on-the-job training, they built that relationship, and that was ongoing with mentorship. And so this we feel is an important aspect of this on-the-job training. And as I mentioned earlier, like we need to have a really structured approach. If other countries want to do this, they need to really think about thoughtfully design and sequence their training materials. And it's very important that all trainers need to have additional skills to be able to be mentors. And finally, what I would like to really mention is that if we all join hands, we will not have to hear another story like that of one. So thank you, everybody. Next slide. Before I end, I would really like to thank National Health Training Center, Government of Nepal, FIGO PPIUD team, particularly Professor Arul, Anita, and all the team members, NESOG, PPIUD team, and most important are the facility coordinators and the mentors who have really helped in taking this forward and have embraced this as part of their regular activity. Thank you so much.
So thank you very much to all the speakers. I'm going to go a few minutes over time and then just ask some of the questions. Can I please ask the panelists to respond very quickly? First of all, I'm going to go to Dr. Anita Makens. There was a specific question to you on to ask whether the postpartum IUD was done by the government, and what do you suggest for the countries where governments have substantially low fundings, how to proceed with this? And then at the same time also, Anita, if you can ask, there's quite a few questions on plans for monitoring evaluation, especially for quality of services. I believe that will be addressed in one of the follow-up webinars, but please, can you confirm? Over to you, Anita.
Okay, so with regards to the first question, the implementation of this project lay with the national societies, and they worked in partnership with the government. So the project didn't fund the purchase of any of the materials in terms of IUDs or contraceptive devices. What we did purchase was the training, some of the training materials. So, for example, the Mama Use. So, I mean, what would be interesting, whoever asked that question, if you can listen to the third webinar, which is in 2 weeks' time, where we actually look at the cost effectiveness of IUD in terms of rollout at a national level in Bangladesh and also in Tanzania. And we have another group also talking about rollout in Rwanda. So I mean, it's an incredibly cost-effective technique, and you actually save more money than you spend. And so I think governments and ministries need to take that on board, and of course donors perhaps helping with money up front. But actually, it seems like this initiative has demonstrated that you save more money than you actually spend. And with regards to the second question, I wasn't clear. So quality of services, we're still going to talk about community health volunteers and their involvement. We're going to talk about task sharing, and then we have the health economics one, which is the third webinar, and we're also going to talk about counsellors in the subsequent webinar. So they're all different aspects of maintaining quality of services, and they're really just to display the fact that it's very context specific. So although we had an overall idea about how things run in country, each country then made it relevant to their own setting, and this required different aspects in order to maintain quality. In terms of monitoring and evaluation, so we had a very intense monitoring system in phase 2, where we had data collection officers actually doing exit interviews on every woman who delivered in the facilities in which we were working. So we knew if they had been counselled, what kind of counselling they had, who had given it, what messages they had taken from the counselling, and then their decision about postpartum contraception. And then if they went for the IUD, then we interviewed them at follow-up at 6 weeks. Obviously, that's not feasible in the long run on a national scale. So in phase 3, which was the sustainability phase, we concentrated on making sure that the HMIS systems in country had postpartum family planning elements in them, so that there could be this constant monitoring of how much counselling was going on, and also the uptake of postpartum family planning methods by method. And that's been more or less successful depending on the country where it was initiated. Thanks.
Okay, thank you so very much. Over to Professor Ratnasari. There were quite a few questions on the challenges between the gaps in the number of insertions versus the counselling provided and consent. Would you like to say something about that?
Yes, thank you very much for questioning. So actually, once we counsel the mothers, they have a chance of refusing at the time of delivery. Also, some of our mothers, they move their places in the antenatal period for delivery. Some of the hospitals in the initial phases were not providing the facilities. So that had been another reason. And the other reason is some of these mothers had contraindications at the time of deliveries, like ruptured membranes for more than 18 hours, or ongoing sepsis, or rarely unresolved hemorrhage. So all those who have consented did not have the chance of having inserted the IUD after the delivery. So some of those are the reasons for the numbers. We could not have the insertions done.
Thank you so very much. Then Professor Muganisi, there was a question specifically on whether you think the promotion of family planning during antenatal care visits could provide a positive response and more preparedness of mothers for postpartum IUD insertion.
Okay, thank you. Yes, I think starting at the antenatal clinic early, it gives time for the woman to take the information, discuss with the families, discuss with the friends, and they come up with a decision. So from what we have done, and in fact, there is a study which was conducted by Harvard. Harvard were doing monitoring and evaluation of our processes. They found that, in fact, the information which was received at the antenatal clinic was vital, was very important for the woman's decisions. So it is important that if you want to succeed in postpartum family planning, it's better that you start early, because there women get the information early, they have time to think about it, they have time to discuss with their families, and then they have time to decide. Therefore, I think starting family planning, counseling, and information during antenatal clinic is a way to go, the best way to go.
Thank you so very much. And then the last question that I'm going to address to Dr. Tapa. I know there's so many other questions, but I do think it will be, a lot of them will be answered in the handouts, and I will really encourage you to download the handouts. I also want to remind you that the material will be available as well as the link to the supplement. But the last question is to Dr. Tapa, and that is specifically on the training needs assessment, how that was done, the minimum of how many cases the trainees have to observe, assist, and do on their own, and what was the plan if they did not meet the competency criteria?
Thank you very much for this very interesting question. First of all, let me mention that this was, as I mentioned earlier, it was a very structured training in which and it involved a humanistic training in which they first practiced on mannequins before they even client. So, and the advantage of this on-job training was that the mannequin was there at the facility and they could just practice it whenever they had free time, when there were no cases, or after their duty time, because it was left there in the facility. So that was one of the advantages, unlike a group-based training where they had to go to the classroom to do the practice. So that was one of the advantages of this on-job training. And it was very structured, in which they have competency on the mannequin before they really move to the client. And in the client, they observe, and under the guidance of the facilitator, then they do the first few insertions, and using checklist, which we all have, standardized checklist. If the facilitator feels that they are competent to do it under observation, then they are left to do it. So first few cases, they are supported. And so much depends on the level of competency of the provider. So it was under the facilitator's discretion on how they move these from the mannequin, which is Mama U, to the client, observing, and then on insertion. So that was how it was done. And there was a certification process in which they had to do at least minimum about 10 insertions before they got their certification competently, that is, and they had to be checked off by the facilitators. And because the facilitators were there with them, these facilitators were their mentors, there was a lot of hand holding in the initial period.
Okay, thank you so very much. We have gone quite over the time, and I think that is also the questions that we have is just shows us the interest in this. And I really enjoyed the challenges and how opportunities were used in this training and how it was incorporated in the different countries. Just a kind reminder that the webinar recording will be available. The presentations will be sent to everybody, and then we are looking forward to meeting you in the next two upcoming webinars as well. Then from all of us, thank you for everybody attendance, and good day to everybody.
Thank you.